it is my absolute honor and delight to invite to the podium Padma Bhushan Dr. K Srinath Reddy, Honorary Distinguished Professor at the Public Health Foundation of India, for the inaugural keynote address. He is also the former President of the Public Health Foundation of India and was the head of the Department of Cardiology at the All India Institute of Medical Sciences. Dr. Reddy was appointed as the first Bernard Loan Visiting Professor of Cardiovascular Health at the Harvard School of Public Health in 2009 and presently serves as an adjunct professor of epidemiology at Harvard. His contributions to public health have been recognized through several awards and honors, including World Health Organization's Director General's Award for Outstanding Global Leadership in Tobacco Control in 2003, Padma Bhushan in 2005, Queen Elizabeth Medal by the Royal Society for Health Promotion UK in 2005, Luther Terry Medal for Leadership in Tobacco Control by the American Cancer Society in 2009, membership of the US National Academies by the Institute of Medicine in 2005, fellowship at the London School of Hygiene and Tropical Medicine in 2009, and fellowship of the Faculty of Public Health UK in 2009. Dr. Reddy, please.
Dr. Amarjit Sinha, Dr. Chatre, and Dr. Jain. I deliberately am addressing Dr. Amarjit Sinha, not as Mr., but as Doctor, because the Latin origin of the word doctor is one who teaches. And there's no better teacher, as you have seen this morning, than Amarjit Sinha ji. Therefore, very much entitled to be a doctor. And of course, I feel very diffident in coming to the podium after him, after that splendid elucidation that he and Dr. Chatre have given of why public policy has to be both multidisciplinary in scope, but very much grounded in experiential wisdom of communities. Let me start by wishing all of you a very happy new year. And what better than to borrow words from Charles Dickens from his work in Chimes, quote, "So may the new year be a happy one to you, happy to many more whose happiness depends on you," unquote. That is the essence of public policy, because happiness of so many other people depends upon people who both formulate as well as practice public policy. So we recognize that public policy involves policies, systems, programs, and community engagement. Frequently, the community engagement part is forgotten. But that is where we must really recognize and respect the role of communities, not only in responding to policies which are being practiced, but also in generating, firstly, the policies themselves, and then applying correctives thereafter when required. Let me start from a health perspective, where Amarjit ji and I had worked together in 2011 on the high-level expert group on universal health coverage. In the introduction to that report, I had written that what we need is not health insurance, but health assurance. Now, that particular formulation is being used for Pradhan Mantri Jan Arogya Yojana, saying that it's health assurance. Indeed, it's assurance in the sense that it is assured payment to the intended beneficiaries who are described and identified. But there is health beyond health care, and certainly health beyond hospitalized health care. And therefore, when we really talk about health assurance, what is the vision that we must enunciate for health assurance? Obviously, health financing is very central to the effort because resources are needed. And we must indeed increase the level of public financing for health. But it has to be substantially tax-based financing, but also additional government budgetary, driven through the budget, but also government-funded social insurance programs or partially subsidized social insurance programs, other insurance programs which are private or community-based. But health financing is only one component of it. In order to deliver the entitlements that the health financing is now supposed to offer, we need a competent health system. We need an efficient, equitable, and empathetic health system to deliver upon that promise. So we need a multi-layered, multi-skilled health workforce. We need adequate infrastructure at all 3 levels of healthcare. We need health management information systems which have reliable, timely, and representative data. We need good governance systems. We need an assurance that drugs, vaccines, and technologies are both available and affordable. And of course, we need community engagement. Community engagement was one that was missing in WHO's earlier 6 building blocks of health. And that's where we must ensure that community engagement is brought back very clearly into the picture as well. And that's the intent of this dialogue as well. But even that is incomplete. So if we think of 3 concentric circles, we are really talking about the central circle being health financing, the second circle being a functioning health system, which then delivers upon the promise of universal health coverage provided by the health financing. But we need the other concentric circle outside, which is the entire array of social determinants of health, which act broadly at the societal level in terms of water, sanitation, food systems, physical environment, social stability, but also at the individual level, though that too is socially determined, at the level of education, occupation, income, gender, and participation in social support networks, availability of social support networks. Only when that outer circle is also there to complement the other 2 circles, then we can think of a healthy society with health assurance. So we are, let me go to the next slide as well. I consider it a violation of human rights to subject people to, to pulverize people with PowerPoint so early in the day, but therefore I've chosen only 2. It's unfortunately the problem of people in the medical profession and particularly even in the public health profession to have too many PowerPoint slides. Social scientists generally desist from that, but I beg your indulgence because I'm only using the second slide again, only for, this is a fuzzy slide of the Sustainable Development Goals, the 17 Sustainable Development Goals. Fuzzy, not only because it's reproduced from a UN publication, but fuzzy also because the progress thus far has been extremely hazy. The UN itself confesses that very little progress has been achieved, and there is a lot of ground which is unlikely to be made up before 2030. But this is essentially to point out the various elements of human and societal development which need to be addressed, not as separate numbers, but as an integrated matrix of human development, which is what this particular consultation aims to do. We recognize very clearly that all of these are interlinked, and health and nutrition are linked to all the other SDGs, and bidirectionally in most of them. Whether we are talking about SDG 1 in terms of poverty alleviation, whether we are talking in terms of food systems, and SDG 2, and whether we are talking in terms of education, whether we're talking in terms of urban development, whether we are talking in terms of environment, everywhere we find that health and nutrition ultimately are interlinked to those, and quite often there's a bidirectional element as well. So from an era of reductionist science, we are now entering into an era of complexity science, where we have to understand all of these linkages and try and elucidate them so that we can apply the appropriate solutions. Even quantum physics, the ultimate of reductionist sciences, which has even broken atoms into subatomic particles and then ended up with quarks, is now looking at complexity science as part of the entire quantum physics and looking at the quantum universe. So we really need to look at all the factors as a constellation of many complex adaptive systems. And these complex adaptive systems, whether it's environment, whether it is agriculture and food systems, whether it is health, all of these are coalescing or colliding with each other. And we need to understand those dynamics if we have to apply solutions. For example, agri-food systems are related to the environment, again, bidirectionally. Climate change influences health systems, and health systems in turn influence climate change, again, bidirectionally. Then we recognize that gender, education, and health, all of these are very much intrinsically interrelated. So changes in one can have an early visible impact on health, but can catalyze a chain reaction which can influence others. Like, for example, nutrition impacts health, which impacts education, which impacts occupation, which impacts income, and again, the feedback loop occurs. Now, we also recognize that if we pick up a few of these just as exemplars, if we look at economic development and poverty alleviation, which is the number one, we recognize that there is a bidirectional relationship between economic development at the population level and health of the population. We know from the Preston Millennium Development Curve that by the time per capita income rises to about approximately $5,000, where it starts plateauing off, till that time, there is a fairly sharp relationship between life expectancy of the population and the per capita income of the population. But we also know that it's not just the per capita income or the rate of growth of income in that population, but the equitable nature of distribution of that income that matters. We know from Spirit Level, published by Wilkinson and Prickett, that countries which have a higher level of income and social inequalities, particularly income inequalities represented by Gini index or other indices, have lower life expectancy at the same level of per capita income than countries which have a better equality index, which have lesser degree of income inequality. You just have to look at the OECD countries and look at the 8-year difference in life expectancy between USA and Japan. And indeed, we recognize that across the world, we find these differences quite clearly manifest. But even before Thomas Piketty wrote his treatise on inequality, we had R.H. Tawney, a socialist theologian, economist from the United Kingdom in the 1930s. In his book, Equality, he writes that equality of opportunity is decorous drapery without equality of circumstances. Quote, with massive inequalities where many are denied an adequate education, unable to access effective health care, and housed in slums, equality of opportunity is nothing but more than a cruel jest, the impertinent courtesy of an invitation offered to unwelcome guests, in the certainty that circumstances will prevent them from accepting it. Well, his lordship, the feudal lord, could well invite the serf for dinner, but if the condition is that the serf must come in a tuxedo, then obviously the serf cannot make it. Well, basically, Tawney says, what we need is not just an equal start, but an open road. That open road is created by a variety of other social conditions, and that we must pay attention to. Then we also recognize that health is subjected to the cumulative impact of assault by an assembly of adversities over a lifetime. And this is what really impacts the health of individuals as well as of families. And this multitude of inequities must be addressed, not only for that generation, but also looking at the impact which is intergenerational. Now, the intergenerational impact of inequalities is easily understood in terms of the social pathways. If parents are uneducated or less educated, if the parents are poor, then that poverty gets transmitted to the rest of the family in terms of limited opportunities, and therefore that we understand ill health also gets transmitted. But we now know that there are biological pathways of intergenerational inequality which are transmitted. We recognize the impact of what are called epigenetics, where genetic expression is substantially conditioned by the nutritional effects as well as exposure to a number of other elements, whether it's stress or pollution or other elements. And that carries not just for one generation, but carry across multiple generations. If we now know that if a pregnant mother is undernourished and a child in the early years of infancy is undernourished, that child is much more prone to develop adult cardiovascular disease and diabetes pretty early in adulthood. That's the epigenetic impact, where the genes are structurally not altered, but the gene expression is not altered. But if the baby in the womb happens to be a female fetus, the undernutrition of the mother affects not only that baby, but also the developing eggs or ova in that particular baby who is still in the womb. So it is not just the child yet to be born, but the child yet to be conceived who is affected by intergenerational inequalities. So unless we recognize these pathways, we'll not be able to really ameliorate and address the issues of human development, which are indeed intergenerational in so many senses, both social and biological. So we now also recognize that there's a microbiome, that there are trillions and trillions of bacteria and other microbes that are living in our gut and over our body. And they are essential for our health, for immunity, for producing vitamins, and for guarding against pathogenic bacteria and microbes. And they really shape us. So when we refer to ourselves as the royal we are not only talking about ourselves out of arrogance, but we are talking about the various microbes who outnumber us and live with us. But their genes, along with ours, actually form the supergenome, which influences our body. So what we eat is also not only for us, but for the microbes. So if you eat a fiber-deficient food, those microbes are going to rebel. And these are the important elements that we must understand as to how multiple determinants are so closely interlinked and are there. Then we must also recognize, when we talk of equity, that equity exists in two dimensions. Very often, when we talk of equality of opportunity or equity, we talk of in terms of one dimension of horizontal equity, in which we say that every single facility that is offered, service that is offered, must be equally offered to everybody. But we also need to think of equity in the vertical dimension, where people have been deprived, people have been disadvantaged, have suffered the impact of those inequities. We need to ameliorate those gaps and ensure that even the opportunities that are not offered are not hindered by pre-existing and concurrent inequalities that exist. So that vertical and horizontal inequity dimensions both have to be combined in any human development approach through public policy. So obviously, when we're talking about something like a health insurance program, which may not be immediately universal for everybody, or a health assurance program in terms of financing, we not only have to look at certain services being available to everybody, maybe additional services or additional resources being provided for those who have been extremely disadvantaged, so that you can actually bridge the gaps. So this is absolutely required. Recognizing and redressing vulnerabilities becomes a very important mandate for public policy. Now, we can, of course, talking purely of economic instruments, fiscal instruments are absolutely important. They act as a wonderful nudge. For example, raising tobacco taxes, raising taxes on ultra-processed foods, raising taxes on sugar-sweetened beverages. By increasing the cost of the unhealthy product, you can drive down consumption. And that can be very beneficial apart from raising tax revenue, of course, but that's the secondary objective. The important thing is to drive down consumption. And public policy can be very, very impactful in this area. Public policy, we can provide both incentives as well as disincentives, the carrot and the stick. Public policy is like a frozen carrot. It can be both the carrot and the stick. But we are often told that it's a matter of individual choice. You're creating a nanny state. You cannot allow the state to interfere with personal choices and liberties. Well, in a democratic society, choice is important. But choice does not occur in a vacuum. Choice is either conscious, based on the right or wrong information. Choice is conditioned, based on aggressive marketing and promotion and peer pressure. Choice is often constrained by economic conditions. Even if somebody knows that they have to consume 5 helpings of fruit and vegetable a day, they may not be able to afford it because of financial reasons, and they may not be able to afford to buy the healthier oils and may have to settle for the unhealthy trans fats. So we must recognize that public policy cannot be hindered by arguments of libertarian protests. Then coming to nutrition. Well, we know that nutrition is absolutely vital for health, but also through health for economic productivity, and therefore for progress of countries and for overall human development. Economic historian Robert Fogel, who won the Nobel Prize in 1993, wrote that improvements in worker health from better nutrition is a significant factor in the long-term economic growth. He estimated that half of Britain's economic growth from 1790 to 1950 was entirely because of improvement in the nutritional status, which impacted upon health and thereby on productivity. Of course, during the same period, Britain was responsible for the Irish famine and the Bengal famine. That's a very different issue. Our own nutrition was affected. But basically, this particular argument of Fogel has been very well described and dissected by Angus Deaton, who himself got the Nobel Prize in Economics later on, in the Journal of Economic Literature in 2006. And it's very clear that nutrition is one of the very important factors in human development, which drives health as well as other areas of human development. But we recognize that there are many phases of malnutrition. What was called undernutrition still remains, but what is called overnutrition needs to be redefined as inappropriate nutrition, because we are no longer talking about calorie excess. We are talking about inappropriate nutrition intake, which results in body adiposity, which is unhealthy. And also we are talking about micronutrient deficiencies. Even so-called overweight, obese people can be micronutrient deficient. And even thin people can have excess abdominal fat. 1/3 of India's diabetics are thin diabetics. And that's because of the kind of food that we are actually feeding them, or they're forced to feed themselves. So the whole idea of having crop diversity and nutrition, dietary diversity becomes very important in our context. And there again, public policy becomes very important. And as Sinaji said, we are quibbling about what the standards are without recognizing that there is a real problem that needs to be addressed. It's time that we all recognize that India's national bird is the peacock and not the ostrich. Coming to education and health, well, with Vrindaji here and Amarjit there, I cannot really talk about the importance of education in human development. But let me quote from the Incheon Declaration of 2015 of how SDG 4 is vital for health. Quote, education endows the skills, values, and attitudes that enable citizens to lead healthy and fulfilling lives and make informed choices. So if we are really looking at this, values, attitudes, and informed choices, and the impact of education on health, education enables greater access to health information, increased opportunities for higher income-earning occupations and employment. Higher income leads to better living conditions, better homes, better sanitation, better water supply, better food, of course. Education trumps income. That's a very important lesson that we must learn. Even at the same level of income, a person who is educated generally can access better health services and also take better self-care. And that is a very important element that we must remind ourselves. So even as we are fast-tracking education and trying to raise incomes, fast-tracking health and nutritional literacy becomes very important. Then education makes a person more, has greater health-seeking behaviors, more adapted self-care, less addictive behaviors. Now, there is a definite inverse relationship globally between tobacco consumption and the level of education. Then there is a greater opportunity for participatory decision-making in healthcare, better insurance literacy, and now better digital literacy, which becomes important for health and development. So education becomes very important. Briefly, I'll touch upon also climate change and health. There is a great impact on vector-borne diseases, waterborne diseases, and zoonotic infections, heat effects, extreme heat effects, extreme weather effects. The agriculture and food systems are impacted. Now we are already operating at the height of temperature tolerance of wheat and rice in this country. For every 1 degree centigrade further rise in temperature, in South Asia and Sub-Saharan Africa will have a 10% reduction in staples. And even the quality of food would be affected. The Data Sciences Center of Columbia University estimates that if the present conditions continue, India will have 49.6 million zinc-deficient persons, 38.2 million protein-deficient persons, 106.1 million children with anemia, and 396 million women with iron deficiency by 2050. So we have a huge challenge in terms of the impact of climate change on nutrition. At the same time, we know that food systems, as they are currently operating, are also aggravating climate change. There's a bidirectional relationship. Similarly, health systems, which are affected by climate change, are also aggravating climate change. 5.3% of global greenhouse gas emissions come from the health sector. 30% of that from the infrastructure and 70% from the supply chain. This may be less in India, but as we are now building up our own infrastructure, we have to make sure that we have both climate resilient and climate smart food systems and health systems. But public policy is not generated in vacuum. Enlightened policy needs scientific credibility, financial feasibility, operational steerability, and political viability. So it is the duty of research, the purpose of research is to provide evidence-informed, context-relevant, resource-optimizing, culturally adaptive, and equity-promoting recommendations for policy and practice. This requires multidisciplinarity. It requires contextual knowledge, and that springs from communities but also we need to bridge the gaps and the silos that exist between academia and ensure that multidisciplinarity really creates the wealth of knowledge that is required to inform and advance policy. So we do require research that is done at multiple levels, but micro-studies, which Amarjit ji has spoken about, are absolutely important, because we need to understand what is happening and why it is happening, and what specific interventions work and what do not work at the ground level. And that experiential wisdom has to be generated from the community level. So we, on one hand, we do require for policy multidisciplinary research that bridges knowledge from multiple streams, even at the policy level, but at the implementation and operational level, particularly ground realities are required. So when we are really talking about complexity, we should not be deterred by that complexity. We have to find the solutions for that. And our approach must be like that of a modern camera. The camera has a zoom function which focuses very sharply on a specific thing and then finds what it is and tries to put a label and find the solution there. But it also has a panorama function which places everything in context. And therefore, public policy has to take both of them into account. And if I may also quote a little from the Indian epic Mahabharata, without any religious connotations. Arjuna was supposed to be a brilliant warrior who, when Drona asked his pupils to aim at a bird, while others saw the tree or the whole bird or the wing, he only saw the eye. But the same warrior, when he was put in Kurukshetra, was unable to really launch into battle because he was uncertain what to do. So Krishna had to show the Virat Rupa, the cosmic configuration, and so that Arjuna could identify his specific role. So our business has to be that. We have to perform our specific duties in the right manner, but unless we understand the big picture, we'll not be able to position ourselves appropriately and perform even that to the best of our ability. So that fusion is absolutely important in public policy. So we also recognize that public policy, in order to make multi-sectorality a multi-sector reality, requires multiple levels of coalescence. At the highest level, at the policymaker level, whether it's the Niti Aayog or the Prime Minister's office, at the mid-level, at the level of the civil service bureaucracy, and at the ground level, at the level of the functionaries, everywhere there has to be a very clear-cut alignment. But one of the important things that we must do is people will continue to function in silos and sectors, because unless we show them what is a win-win situation, they're unlikely to exert themselves. They're unlikely to move beyond their sectoral mandates, beyond their policy and program deliverables, beyond their limited budgetary lines. Therefore, you will have to really point out the positive externalities as well as the negative externalities and show that if you act, then this is likely to benefit not only the other sector, but will loop back to benefit you in this manner. Otherwise, if you do not act, this is going to hurt you in this manner. So the positive and negative externalities of actions, each action, have to be clearly outlined, and I believe the book also must actually ensure that approach is taken so that you can actually carry conviction to people who are change agents in other sectors. So there is a price to pay for inaction and for incorrect actions. There's a prize to be won for timely, relevant, and effective actions. And both of those need to be very clearly defined. And we now recognize that community and ground is a very important element. We have seen that from Thailand, we have seen that from Brazil, we have seen that even in Nagaland. In Thailand, we have the National Health Assembly as well as the local health councils. In Brazil, we have municipal councils who have monthly meetings in which they take not only they look at the accounts as well to see how the public money is being spent on various programs, and they can call the implementers into account. In Nagaland, we have seen the Communitization of Public Institutions and Services Act passed in 2002, and the health communitization committees, which include the Gram Buras and the which are the village councils and other citizen groups. And whatever evaluation has been done has shown improvement in provision and utilization of services and infrastructure for health. We have examples from Kerala, we have examples from Bangladesh of how good health has been achieved at low cost. And therefore, everywhere we recognize that community has played a very critical role, and therefore we can only ignore the contribution of the community at our own peril, not merely to treat them as beneficiaries, but to ensure that they are active participants in developing policies and programs, in implementing them, in partnering in the implementation, in monitoring, and also in evaluating, and ultimately providing the correctives when needed. So it is that level of community engagement that is absolutely required. I believe that the public policy dialogue will address all of these issues and certainly come forth with the various volumes. I was interested in seeing Dr. Amarjit Sinha say 6 volumes will go to 12, 12 will go to 18, 18 will go to 24. He's dealing in sixes, like Rinku Singh. 5 or 6 sixes, straight away. Okay, good. So, in conclusion, Simone Weil said, "Attention is the rarest and purest form of generosity." Thank you very much for your gracious invitation and for your generous attention. Thank you.